Our presenter today is Stephen White. Stephen is a licensed genetic counselor at Bliss Cancer Center. He has been helping patients with hereditary risks for adult onset cancers since 2015. Please welcome Stephen.
Mic back. All right, can you hear me now?
Yes.
All right, good to hear. So my name is Stephen White. I'm a genetic counselor at the Cancer Center here at Ames. Today, I'm planning to talk to you about when to consider getting a risk evaluation for hereditary cancer. The way I've planned this talk is it may be a little shorter than some of the other talks you get, but I'm hoping to leave a lot of room at the end for questions. So we're going to start off just by defining a few things. What is hereditary cancer risk? Well, it's basically having a higher risk than somebody else your age due to your genes. So the genes are the things you're getting from mom and from dad. I like to describe them to my patients as the instructions. So they're the instructions about how tall you might get or what color eyes you might have. And they also have instructions to keep you healthy, to help your body grow and develop. In a hereditary cancer risk evaluation, we're looking at the genes the body uses to prevent cancer. Sometimes you may hear us even talk about them as tumor suppressor genes. So it's ways that the body prevents a cancer from starting in the first place. But beyond that, it may also help the immune system identify, hey, something's wrong here. We need to get rid of this cancer long before it becomes a tumor. So if you hear me talk about cancer genes today, they're not necessarily the bad things. They're probably the good things that are keeping people healthy. And so if you've got a hereditary cancer risk, it's because that gene no longer functions correctly. So the gene's the instructions. It's telling the body how to prevent cancer. If the body's getting the wrong instructions, the body may not be able to compensate and prevent that type of cancer. And so that's what we'd be looking for in our hereditary cancer risk evaluation. Do you have a change to one of these genes that's putting you at a higher risk than somebody else your age? And so that's a type of test that's usually done with a blood draw, and then we would try to interpret it from there. Long before we decide on something like whether or not to move forward with a test, we're going to try to figure out why would you do it in the first place. A lot of this comes down to what can we do to improve your health care based off of learning this information. If I could prove that you've got a higher than average risk for cancer, that's going to mean you're going to get access to above average screening options. That might mean things like maybe you would start a certain type of screening earlier, like mammogram. Or it might mean that you're recommended to have colonoscopies more often than others. It may be that we say, let's add to your regular visits something like a thyroid ultrasound. Things that most people wouldn't need to get, but you've got a risk that's higher than average. Let's at least give you the options on what to do about that. Now, as you might imagine, if that applies to you, it may apply to your relatives. So any gene mutation you have, somebody else in the family may have as well. We're going to talk about that a bit more later, but for now, I just want you to know that the wider family may benefit from knowing, do they have a specific type of risk? Would they benefit from starting screening more often, but also younger? This is especially important for younger generations. You may already be doing some of this screening, but maybe some kids or nephews, nieces, they haven't started. And it may be helpful for them to know, should they start sooner than their peers. We may also talk about what to do for those who already have cancer. Quite a few of my patients have already had a diagnosis or are going through a diagnosis. There are times where we would change what kind of recommendations that doctors would consider based off of a genetic risk. The first example I have mentioned here are surgical recommendations. Now, I want to be very clear, doing a genetic test does not mean you're signing up for surgery. But it does mean that, hey, we know you've got a higher risk for this type of cancer to show up again, some individuals may decide, I want to do a more aggressive surgery or a more complete surgery. They may decide that, hey, I want to handle my care a little bit different to try to prevent that additional risk in the future. Now, this is true for some of the genetic findings that we see, but not most, which is there are some medications that may work better for somebody with a specific gene mutation. That there's a vulnerability in the cells themselves because of that genetic change that we can target with certain types of medication. That would be something an oncologist would review. It doesn't mean if you do a test, you're going to get a certain med, but it might mean that your doctor has more options to pick from, and you can decide with them if that's a good fit. I want to lay this out in terms of at least one example. So up on the screen, I've labeled a gene here called MLH1. You do not have to memorize any of the genes that I may mention today. But for what it's worth, this one's associated with something called Lynch syndrome. A lot of these genetic syndromes get named after the doctor that described it. So this one was named after a physician called Dr. Henry Lynch. He was working with families out in Nebraska, and he started seeing these certain families have a really high incidence of colon cancers and uterine cancers. And beyond that, there were a few other cancers that were showing up in these families. So if you were to do a genetic test and I could prove this test shows a positive result for Lynch syndrome, that would mean you're at a much higher risk for colon cancer. So let's talk about doing colonoscopies more often. If the average time period a person would wait between colonoscopies is about 10 years, yours might look a little bit different. Might look like 5 years or 3 years or something else. It might look like that we're going to recommend that as part of those colonoscopies, you're getting additional screening too. So it's not as high of a risk, but some individuals with Lynch syndrome can also get stomach cancers and cancers of the small intestine. So it may be the same day that you've done all the prep work you need to already for that colonoscopy. While you're out, they can also do the upper endoscopy that goes and checks out the stomach and small intestine. Given the fact that it's not as high of a risk as colon cancer, it likely wouldn't be every time. It might look like every other colonoscopy or every third colonoscopy, you might get one of these. But this is where we start introducing additional screening that you may not already be doing. Beyond that, we are seeing an increased risk for those with Lynch syndrome to have cancer along where the body produces and pushes out urine. So this is the bottom of the kidney that goes into the ureters that drain into the bladder and to the urethra and outward. There can be a higher cancer risk there for those with this type of gene mutation. And so your body already has a way for us to determine, hey, is there cancer cells that are detectable? And it might be as simple as, rather than go through all the prep work of something like a colonoscopy, just doing an annual urinalysis, peeing in a cup once a year as part of an annual physical and see, hey, let's address to see if we're seeing any cancer risk here. Talking about surgeries again, beyond doing something like treatment for a cancer, we may look at preventative options. Again, doing a genetic test is not signing up for surgery, but some individuals may decide, hey, I've got this higher risk. We can do screening, but is there anything else I can do? Some women decide that they're going to do a total hysterectomy as part of Lynch syndrome. This is because the second highest risk for Lynch syndrome is uterine cancers. And so what we typically go about this with is trying to address it at a stage of life that's most appropriate. Basically, we're not telling our patients, especially the young ones, you better have kids now or never, because we're taking you to surgery. Far from it. We're trying to say, have as many kids as you want, when you want, but when you feel like you're done, whether you're stopping at 0 or you're stopping at many kids, when you feel like you're done, we could talk about surgery as an option. Taking out the uterus is a great way to significantly reduce that risk. Beyond surgeries, we are looking at medications again. We have evidence that's showing that oral contraceptives are actually preventative for ovarian cancer, That's a lower risk than the uterine cancer that comes with Lynch syndrome. But if we're finding, here's the positive result, what can we do about it? One of those options may be, depending on your life stage, we're saying this medication may actually provide a preventative benefit against ovarian cancer. One of the medications I've found most interesting that's been showing up in the last few years is actually aspirin. We're seeing that individuals with Lynch syndrome who take high doses of aspirin actually reduce risk of colon cancer. I don't think we fully understand why yet, but we are seeing this pattern over and over again that those with Lynch syndrome who are already on high doses of aspirin actually get colon cancer less often. And so we're just in the starting stages of trying to figure out when do we do this, what doses, how long do we do it? But it may be that as long as you don't have a separate health reason why aspirin wouldn't be a good fit for you, your doctor may say, hey, do you want to try this option? Now, I picked this as an example because it shows a lot of different types of cancers, different ways that we may try to address evaluating for, preventing certain types of cancers if you find a genetic risk. Lynch syndrome is not the only one, but it is one that can be seen more commonly in the American population than some of the others. Now, when I say common, that's a really relative term. So hereditary cancer is actually pretty rare. What we're seeing is that most individuals with cancer do not have a known hereditary cause. If you look at this blue section on the pie graph, it's showing that we're thinking about 70% of cancers are just sporadic. I think it's kind of a fancy way to say we're not really sure we found a specific cause, but it does have a lot to do with the fact that anybody can get cancer, and the longer somebody lives, the more likely it could happen. And we're seeing that most cancers kind of seem to fit there. In that purple wedge, about 20% of cancers we think may be familial. This isn't necessarily genetic. This is where you're seeing patterns in your family, but those patterns may not be genetic. It may be that the same type of cancer showing up in the family, like multiple lung cancers. Maybe it's not your genes. Maybe it's the radon level in the house that you own. It may not be your genetics. It may be, well, what was your house next to? Farm chemicals, a local factory. Did you share the same water source? Did you have the same dietary preferences? Did you have similar lifestyle choices? There are many things that impact the health of individuals and family members that aren't genetics. And so we may see family patterns, and you may even know of family patterns in your family, but that's not proof it's your genes. It may be something else. For us to find that genetic risk, that's where the blood draw test comes in. We're taking a sample from the blood of your genes. So if you think of your DNA like a book, a gene is a chapter. We're looking at specific parts of your inheritance patterns to see, can we find something that's not functional and would explain that risk? So maybe about 1 in 10 cancers, though it does vary from cancer type to cancer type. So since we are looking for something rare, it would be helpful for us to determine, well, what looks like a hereditary pattern. The main thing we're looking for are similar cancers showing up in individuals and families. So if you know that you had a certain cancer and your dad had the same cancer and his mom had the same cancer, well, that's a pretty good clue that something is causing this cancer to show up multiple times. It could be genetic. We could take a look. Built into that are the multiple generations. So parent to child, are you seeing that inheritance pattern? Beyond that, we are also looking for early ages of onset. A lot of the cancers that get diagnosed are in somebody's 60s, 70s, 80s. You don't often see a lot before then. So especially if you go to an oncology waiting room, you're going to see that there aren't as many young people there. But if you do see cancers at young ages, and from our perspective, for hereditary cancer, that's usually 50 or younger, we do start looking at hereditary risks as a possibility. We're wondering, this person didn't have as many decades of exposure or other lifestyle issues come up that would put them at an accumulated risk? Is there something else that's causing them to have something of a head start toward a cancer where they would get it young? We're also looking for individuals that have multiple cancers. Unfortunately, cancer is fairly common in the American population, but getting cancers more than once isn't. This isn't the sort of thing where you're going to your dermatologist and every few years they take off another skin cancer. This is more like the big ones that we're kind of talking about today, like colon or uterine or breast cancer. If somebody's getting that multiple times, we're wondering if there's a common cause. The same genetics you have in one part of your body, it's the same genetics you have in another part of your body. So if there's a genetic risk that's affecting multiple body systems, that might be why we keep seeing cancer. The next one, I'm not going to give a whole lot of examples for rare cancers because they're rare. You may never hear them again. And in fact, for some of these, it may be your doctor says, I've never seen this before. So it's not your job to make sure, hey, every rare cancer I hear in either me or my family, is it genetic? What you're kind of looking for are the doctors that are saying, you usually only see this when it's part of a syndrome. Or, I heard about this when I was in med school and it was associated with this type of hereditary risk. So if you're hearing those clues, that might be a good time to either ask for or agree to your doctor's referral to go see a genetic counselor to evaluate this. And then there are specific pathology features. Pathology basically is somebody's looking at the tumor sample under a microscope and trying to see what is here, what type of cancer it is, subtype, what does it respond to. There are certain things that they may see that clue us in on this is often associated with genetic risk. And so if you're reading a pathology report in your MyCharts or in your medical records, and it says right at the bottom, you may want to evaluate for genetic risk, that's a good clue too. But your doctor should be able to look for that also. What I'm going to do next is kind of show you, if you're interested in trying to find out, am I or my family a good candidate for genetic testing? How can you find that out? I do think I may have put some of my slides backwards here, so I'm going to try to navigate this okay. But this first we've got this website that's really hard to read here, but it's the Bliss Cancer Center website. If you were to log on to the Bliss Cancer Center website, this is where I've got to click through, you would come to a page like this in a submenu about genetic risk education. And so scrolling through that toward the bottom, we've got this button here that says Start a Risk Assessment, and that takes you to this page. So Bliss Cancer Center has partnered with a commercial laboratory called Ambry Genetics, and they've provided us a software that helps us calculate if somebody's at a high risk for hereditary cancer. And you can basically access this anywhere you've got internet connection. It will ask you for name and date of birth, and after that, it's trying to figure out, are there patterns in your health or your family's health that suggest hereditary risk? And so you may want to set aside some time for this if you decide you want to do this. The more cancer diagnoses are in your family, the longer it's going to take. And so it will ask you things like, have you ever had a cancer? If so, what type? What age was it at? And then it starts moving on to other relatives. Did you have multiple siblings with cancers? Aunts, uncles, cousins? The more relatives, the more questions it's going to come up with. Okay, that cousin, what type of cancer was it? So depending on how many relatives you have and how many cancer indications, you may want to set aside enough time for it. But eventually it will come to our side of things where we have it monitored and we're looking to see, does anybody who's taken our risk assessment, do they qualify for a genetic evaluation? And you may be getting a phone call later from one of us that's basically saying, hey, we saw you took our online questionnaire. You qualify per national guidelines to consider genetic testing. Do you want to set up an appointment where you come on in and we talk more about that as an option? And so that's one way that if you want to start this process yourself, that you have access to that. I also have here a QR code. I'm going to leave it up here for a little bit right now if you want to scan it, but I'm also planning to have this on my last slide. So when I'm going through questions, it'll be up there as well. We also have toward the back, actually, some of you may already have it, that piece of paper with a big QR code on it. That's actually the same QR code, yes.
He says scan it. Does everybody know what he means? That means, yeah, you take your phone, you open up your camera, hold over it, and then there should be like a yellow box that shows up. You touch the box and it will take you to that page.
Yes, thank you, Vicki.
Yeah.
Right, I'll pull this one up again toward the end also. So what should you expect if you decide you want to go to one of these appointments for a genetic evaluation? The first thing I want to mention is, once again, setting aside enough time. Same reason as before. If you've got a big family, a lot of relatives with cancers, I'd be planning to ask you more about that. I'm not expecting you to know all the details, but I am trying to look for patterns. And if you've got a lot of affected aunts, uncles, cousins, we'll be talking through that. Now, I ask my patients to set aside either an hour to an hour and a half. We usually don't need all of that time, but it's built in so that we do have enough time to work through it. Toward the beginning of an appointment, I really like to get a sense of what are your goals for the appointment. Some people know right away, Stephen, I'm here to get my blood drawn for the test. All right, we're going to work toward that together. But other individuals may be more curious and say, I'm not sure how I feel about genetic testing. I just want to know what my options are. And we can work toward that too. There may be other reasons where you're thinking, hey, I'm not sure about this genetic test, but I want to understand if there are patterns here and if there's screening I can do outside of genetic testing. And yes, there are options like that. So basically, I'm trying to get a sense of what can you and I accomplish together and try to get you closer to that. As part of the evaluation, I am looking pretty deep, not only into the family history, but your health history. So I'm trying to get a sense of what's been growing that shouldn't be there. So those are the tumors, the polyps, the cancers. If it started where, hey, my mom said I had this thing when I was born, we're going to go all the way back then. But if it's, hey, I started colonoscopies when I was 50, we're going to start that. The family history, we are looking into 3 generations. So your first degree relatives are your parents, brothers and sisters, your children. We're going to focus quite a bit on them because they're your closest relatives. You have the most shared DNA with your close relatives. Second degree relatives will also bring up grandchildren, nephews, nieces, uncles, aunts, and we're going to try to get a sense of what types of cancers have been showing up there. Third degree relatives, we may spend some time there. So that's going to be first cousins, but also we're going to get into some generations that we don't have much information on anymore. So great uncles, great aunts, great grandparents. I often don't spend a whole lot of time there because we often don't have nearly as much information. But if you know for sure, like, hey, nobody mentioned cancer, we're going to leave it there. Or I don't know who had what, but it was about half of them had this. Those are the kinds of details I'm looking for further out in the family. We also plan to discuss genetic testing as an option. Arriving at the appointment doesn't mean you're saying yes to testing. It means we're going to see, are you a good candidate? Do we think we have a test that could help you? And would the test actually match the goals that you had set out for this process? If we are going to test, we're going to be doing a blood draw. Now, I like to point out that specifically this is non-fasting because I still have patients coming in skipping breakfast, and you really don't have to do that. But if we decide, hey, we're going to do a test, we'll probably do a blood draw the same day. About 2 to 4 weeks later, you would expect a phone call from me or one of our staff to explain the results. Now, I might catch you at the grocery store or doing something else, so I'm not planning for that initial call to be very long. Maybe try to give you some of the basics like, hey, we found what was causing that ovary cancer, colon cancer risk in the family. That's what we're going to focus on. Or maybe a quick call where I say, we didn't find a genetic result that explains the cancer, so there's not going to be any changes. But it's initially disclosed by a phone call, and we can decide if we want more follow-up. A follow-up appointment would basically be making sure that you feel comfortable understanding the results and maybe even know how to say a sentence or two to your curious relative, like, oh, I saw that genetics guide. This is basically what it means. But we're trying to figure out, can we get you set up where you feel comfortable with the results and what happens after that? Short-term goals on screening and care, getting established with certain doctors if you need to, long-term screening about what does this mean in the years to come, and also how to share this information with the relatives. If you want to do the extra credit, this is where you could really help me out. Preparing for a genetic evaluation, I'm going to be asking you these questions anyway. If you want to get a head start on it, you are more than welcome to. It comes down to kind of three things in the family history. Who had cancer? What type was it? And about what age? So the who, that one's usually pretty easy, like, his brother or his sister. But if you're telling me, I had a cousin with a cancer, I'm going to ask you, well, which cousin? Was it mom's side, dad's side? Or maybe you'll say, yeah, it was Aunt Betty's child. I'm like, well, was it son, daughter? Was it the first one? Was it 1 out of 5 or 1 out of 10 kids? Now, if we get into the cousins, I'm not going to ask you all the details on all of your relatives. I may do quite a bit of summary there, but once I start seeing there's a cancer there, I'm going to ask follow-up questions at that point. In terms of what type, this one's sometimes tricky. I have a lot of people that come in looking at death records from family members, and they say stomach cancer. Now, from what we've seen, stomach cancer is really rare in the American population. It seems that there was this time period where a lot of people wrote down if they did a surgery to determine if there was a tumor and they found a cancer in the abdomen, it was often just written down as stomach cancer, even if that's not where it started. And maybe then I ask you a few follow-up details about what's your level of certainty here? Are you pretty sure this is it? Or would you feel comfortable with me saying a suspected stomach cancer? But I may ask you more details too on subtypes of cancers. The example I gave actually was more along the lines of a common treatment that I've seen show up in multiple families where somebody in the family got a hysterectomy because of cancer. I think it was ovarian. So I'll probably ask you, what's your level of confidence there? Because what we're looking for is where the cancer starts, not where it spreads to. Where it starts tells us more about the genetic risk. And so I may ask you, was that a total hysterectomy or maybe partial? Or do you think that she had additional treatment after that or surgery took care of it all? That may help me try to refine what type of cancer are we looking at. In terms of what age, this is one I really don't want my patients to stress too hard about. If you're thinking, she had it at 63 or 64, one of the two, that's definitely close enough. We don't have to nail it down completely. I'm looking for roughly decades. So 60s is different than 40s, 50s is different than 80s. I'm trying to get a sense of kind of what time of their life was this happening. Was it early? Was it late? Other things that we ask for are copies of family test results, those who have already done genetic testing. Now, a lot of patients, they come in and they're the first one in their family to even try something like this. But if you know, yeah, my sister told me she got a positive result, go ahead and ask her, is it all right if I have a copy of that? I'm going to have my own appointments. The reason for this is that there are significant limitations in what negative results mean in genetics. So in negative results, if you get one of these, it doesn't mean your family has a low risk for cancer or that there's no hereditary risk at all. It means that we didn't find an answer for the cancer that is in your family. This is because we still don't know what all the causes of cancer are, let alone all the causes of hereditary cancers. And so there are going to be families that do have hereditary risk, and we still don't have a test that can prove it. And so, to try to combat what negative results have and their limitations, we try to have as much information about if there are any positive results. So like if your sister has a positive result, then we can use a negative to prove you don't have that risk. We know what caused the cancer. We checked, you don't have it. If we don't have that test report, you may have to get an answer like, I think it's negative, but we can't quite prove it without that record. The way I like to explain it is actually using an analogy. So if you were to tell me, Stephen, I really like the information, but I forgot to get a copy of that paper. Could you please mail it to me? And you tell me you live in Iowa. All right, so I might be able to get it to you with that information. So I could send out a mass mail and maybe I would get it to the right household. But if you instead give me more specific details, like your zip code, your city, your street and street address, then I can make sure I got it to the right person. And that's how your family's test report works. If it's positive, it's going to have a specific code on there, not too different from an address, where it says this is where the family's risk is. And I can use that to determine you either have it or you don't. But until we know what's causing those cancers, negatives really mean the lack of an answer, not necessarily the lack of risk. So overall, if you can, we'd really like to get a copy of anybody who's tested positive before. Next, you may also want to bring in additional medical records. Not everybody has had all of their health care at the same place their whole life. So if you had had a previous cancer before, and that was in another state, maybe you had started having colonoscopies somewhere else, and you know they've got records on polyps, we'd be asking you, if you can, bring in that information, because I am going to be looking pretty thoroughly at a health history. So as early back as we know anything like tumors, polyps, or cancers have gone. Finally, I have here talking about bringing a support person. So it could be as simple as somebody who knows you well, a spouse, a good friend, your favorite sibling. It could be somebody that will help you kind of fill in those gaps of, oh yeah, the cancer was diagnosed in 2014, right around the time of Timmy's birthday. That's right. And so what I've found is the more people that come from the family to answer family health history, usually we're able to get a better, more accurate picture of what's going on in the family. Now, I also put on here the family historian. A lot of families have that one person that knows everybody's birthday, they know when everybody's anniversary is, and they may know a little bit too much about your health history too. So if that's you, I actually really like you. So you really make my job easier. If you know that, okay, she knows who had what when, go ahead, bring him or her in, because they may be able to give us a much more accurate picture of what we're on the lookout for. Next, I want to talk about some of the common questions I get that kind of make people hesitate. I don't know if this is going to be a good idea or not. When it comes to cost, what we're seeing is that most people actually get this covered by their medical insurance as long as we're meeting medical criteria. And that's where my job is. I'm trying to figure out, are you at a high risk? Are you meeting national medical criteria where we should be offering this test to you? And if so, in most cases, insurance will cover that. If you felt like, you know what, Stephen, just give it to me straight. How much is this? It's about $250. Some patients, that's a high number. For some patients, that's a low number. But if you were thinking, you know what, even if I don't meet criteria, I just want the test, we can make that happen. We just want to make sure that we're aiming at the right thing and that you know what it's capable of before signing up for that. For privacy concerns, this is basically the same as your other medical records. It's got the same protections. If somebody asks you for medical records, you get to decide who gets access to that. But we also have an additional law that's directed right at these types of test reports, called the Genetic Information Non-Discrimination Act. This was passed back in 2008 as a federal law that prevents discrimination from health insurers and employers. Now, this is different than the Affordable Care Act or Obamacare. It's its own law, and it basically means that it's illegal for health insurance or employers to discriminate based on positive results. That means no dropping of health insurance, no changing of rates. That means nothing like hiring or firing based on genetic tests. Now, there are exceptions to this law, but even where those exceptions exist, those are the things usually covered by HIPAA anyway. But for the most part, we just want our patients to know it's got HIPAA protections, it's got additional protections on top of that for health insurance and employment. This is really where I'm going to be opening up to answer more of those questions, things that maybe I hadn't covered in this talk. On here, I've got the QR code again. If you do want to take out a camera phone and scan that, but I'll be available for quite a while with some questions. If you feel like this isn't really the setting where you want to ask those questions, you're definitely welcome to actually come in for an appointment. Again, coming in does not mean you're saying we're testing. It means let's talk about what's going on and what my options are. I've also got up here our phone number if you want to call us up for that. But at this point, I would love to take your questions, and thank you for your attention so far.
All right, raise your, question right here.
I have a question. It's more for my sons than for me. Because everybody in our family has cancer. And now he's about 50 and he had a colonoscopy, but he has to have another one because they found too large of a polyp to remove. And so I don't know, is it best for me to come in, have him come in? I want to know how to protect my kids.
Yeah, thank you for that question. When possible, we want the person with the symptoms to be the one doing the testing. So if this is the sort of thing, yes, there's cancer in the family, but nobody's had those types of polyps except him, he might be the best person to start with. If there's a broader question there, such as, there's this family history of thyroid cancer. That was you. You had thyroid cancer. Well, we probably want to start by testing you. It does depend on what question we're trying to answer. There are also situations where you may find yourself as somewhat of a, what I sometimes call a bottleneck of information. I don't know if that's the best term. Let me know if I can find a better one. But let's say that your side of the family has lots of cancer. Maybe it wasn't you. You didn't get cancer, but 2 out of 3 sisters did, and 4 out of 5 brothers did. And now we're trying to figure out what does that mean for your kids. If one of those affected relatives is still alive and willing to test, we want to start with them. They have 100% of their DNA. You have a fraction of it. Your child has half of whatever fraction that is. And so the further away we get from the symptoms, the less likely we're going to figure out what caused the symptoms. And so I think kind of a 2-part answer, which is that you're trying to get the person with the symptoms, that person to test. But if you find yourself as, hey, this is from my side of the family, and we're going to try to figure out for the next generation, then it might be you, that you might be the best person to test.
And now I am confused.
Okay. So
do you think I should, I'll wait till he has his final test and they check the pathology, but should I come in or should he come in or what?
So at this point, since the only cancer or tumor I'm aware of is son with polyps, I would say son at this point.
Is fair.
But, okay, all right. Unless, and not that I'm saying you do or that you have to, unless you are going to also say, well, I had polyps, I had cancer, now he's showing, and then you want to know for your other kids. So I think if you have and you want to know, it would be her,
Yes.
but if not.
If you've had the symptoms, if you've had those health problems, then it would be.
I don't care about me. I'm old. I don't care about me. I'm old.
Yeah.
I want to take care of my kids so they don't get cancer.
Yes.
That's what my concern is.
And by you doing that test, even if you may not use it for much of your health care, you may be able to help them determine, hey, mom has this risk. Do I have it too? Do I need to do the additional screening because of that?
I don't see a hand up, but there are probably more questions. I did have somebody ask me if I would ask, how does this work? Or is there other criteria for somebody if both of your parents were adopted? So you don't have much information.
This is a tricky one. This actually comes up quite a bit. So if you don't know much about your family history, we do start with your health history. Have you had health problems, multiple tumors, multiple cancers? And if so, I mean, we've got our questions settled. You qualify for testing. Let's go ahead and start with you. The way that testing criteria has been designed historically is that you're looking at that larger family history. And so there is a disconnect between that. There may be people that would really benefit from genetic testing, and we just can't prove it because we don't have the family health information to go off of. And those individuals, they may not qualify traditionally for genetic testing. At that point, we might be looking at more like a self-pay option at that $250. And so someone may elect, hey, I want to do that. I know we're just kind of taking a shot in the dark, but let's go ahead and try it. There are going to be other cases where if you find out, hey, I've got maybe adopted on one side of the family, but not the other, we may try to focus more in on the side of the family we do know. But yeah, that's a tough one. So if we don't know, then we can't really make a really clear evaluation.
So if that person whose parents were adopted, they could come, especially if they've been diagnosed or have these symptoms, come talk to you. That's one thing, and potentially because there's these medical issues, maybe, but still to talk to you just because you're not, it might be valuable that you could still do the genetic testing since you don't have all this information, but they would have to pay for it.
Yes, and that's something we could talk about together.
Okay.
That actually helps me realize that something that I may not have mentioned so far, which is family history helps, but it's not necessarily always going to show us maybe the most accurate answer. So what we're seeing is that if there's a genetic risk in the family, it has to start with somebody. That somebody could be great-great-grandma, and you see the same patterns through the generations. But that somebody could be you, that you're the first in the family to get a new genetic mutation. That's something that we would expect happened at some point when dad was making sperm or when mom was making an egg. There was a change at that level, and you're the first. Now, that would definitely affect you. That would affect your kids potentially and their kids, but it wouldn't affect the others that came before, like siblings, parents, uncles, aunts. So I do work with families where it's not just the family history, and sometimes that's the adopted person. We don't have all the family history, but I've got enough to say, hey, there's something suspicious here. We can start taking a look to see if that matters for you and your descendants.
If there are 3 breasts, 2 Parkinson's, I don't know if Parkinson's is included in this, if it's a gene, but if it's all in one side of the family, when you do the blood test, are you looking for specific, like there's 3 kidney cancers, are you looking for specific cancers since there's multiple and this is all on the paternal side?
Yes, so the way that testing is designed is to be comprehensive for things that cause cancers and tumors and polyps. It's really not designed for other health conditions. So there may be a genetic test available for Parkinson's or family heart disease. That's not the sort of thing that we would be testing for as part of a cancer evaluation. There may very well be a day where that's far more common. But right now, we test multiple genes, but usually not multiple types of health problems. If we're looking for things like there's breast cancer and kidney cancer and other cancers, yes, I would anticipate that the test would be more than capable to look at all of those simultaneously. Some of my patients elect to try to make the test more focused, not necessarily more accurate, but more focused, such as maybe you come in and yesterday you got your diagnosis. Yesterday you got diagnosed with something like a pancreatic cancer, and you're still reeling from that. You need to figure out how to tell your family members. You need to figure out what is a long-term chemotherapy or radiation regimen look like, and you just are not ready to start looking for all the possibilities. You're looking for, how can I treat this? And some of my patients may say, you know what, it could look at everything, but right now I just need to know hereditary pancreatic cancer or hereditary breast cancer, and we can do that. But in most cases, yes, we'd be looking for it all at the same time if it's cancers, tumors, or polyps.
How does this with lymphomas?
Mhm.
Now, is that the same genetic testing? Because there's a variety of lymphomas, blood cancers. Is it a different test or the same type?
Mhm. It really depends on a number of factors, but sometimes it is going to be a different type of test. One of the things that we're running into is there are types of cancer that we haven't developed very good testing for. We don't find hereditary causes for a lot of cervical cancers, lung cancers, and there's a variety of them. Lymphoma kind of falls into that. We don't find a whole lot of hereditary causes for lymphoma. If they exist, we're still not great at figuring it out. The testing that we do have available, we may decide to go with a specialty laboratory that can handle that type of testing. But another factor is if the cancer that we're trying to figure out is in somebody who has a cancer already circulating in the blood, like a leukemia or a lymphoma, myeloma, it may be that we have to get an alternative sample. We don't want to use the blood sample because we're looking at, what did you start with? What did you get from mom and dad? And if we're taking in the cancer cells themselves from a blood sample, then we're looking at the DNA of what changed. Now, some of your doctors may already do that for a cancer diagnosis. We're expecting the DNA of what you started with to be different from the DNA of cancer. That's part of what cancer is doing, is changing those genes to make it more likely it could spread in the body.
How would you find that? Well, like in my case, I have non-Hodgkin's lymphoma.
Yeah.
And I've had it for quite a while, but none of my parents, none of my brothers, none of my sisters, nobody else has it.
Yeah.
Just me. So how would you find a clean DNA?
So at that point, we would probably go toward a skin punch biopsy. So we would take the DNA from the skin cells themselves, which we wouldn't anticipate to have a high level of lymph cells. So that one, we probably have to coordinate more, try to get a physician that can do that skin punch biopsy. We send it to the laboratory. We have to take more time to grow up the skin culture, so it's not as easy to access. It does take longer, but there are ways to do that. If that's truly the only lymphoma we know of in the family, I would anticipate a very low likelihood that we would find a genetic cause.
Would I, but.
Yeah.
So are all blood cancers treated like that then?
So
With a finding a clean DNA to start with?
no, not all of them. It really depends on where are we expecting to find cancer DNA. And sometimes we go back to things like the bone marrow biopsies. Is there evidence that it's in the bone marrow and those cancer cells are generating those blood cells and sending them out into the body? If there's evidence of that, we're expecting a blood sample would come back with cancer DNA that wouldn't actually be beneficial for the type of study we're doing. You're welcome.
I don't know that I followed all of it, so I'm glad we have you to tell us what it is. And
If you decide that you want to study genetics as a hobby, you're going to find that we're basically just a whole field of exceptions. So there's general rules. That's kind of the level we're at now. But the deeper you get, the more we have to customize it based on what's actually going on. And I think that's one of the main benefits of talking through genetics like this is there may be a custom option for you that we can get toward. I'm not expecting any of you to become experts on even knowing what to ask for, but we can often try to work together to figure out, is there a test available? Will it help you get to your medical goals?
Any other questions? Sarah, just give me 1 second. Sarah, I'll get.
Oh, go ahead.
So the cost you talked about was for the initial appointment, and then is the genetic testing itself, that's an additional cost, or?
There is no cost for a genetic evaluation. That's something that's actually covered by the Mary Greeley Foundation. So we're offering for our patients, if you want to talk to a genetic counselor, we are not charging insurance. We're not charging you for that. The cost I put up there is something that you would be interacting with the laboratory for. If we're going through insurance, then it's something the laboratory and the insurance are going to work together on. And in many cases, there's going to be no out-of-pocket cost to the patients. If there were going to be an out-of-pocket cost, there are basically safeguards put in place that you're not stuck with a surprise bill, but you're told ahead of time, this is what you should expect. Do you want us to continue with the test, or should we cancel it no charge?
Hey, Stephen, talk real quick about what do you do when people have hardly any siblings or like really small families? What does that mean for this process?
So similar to how we talked about families who have adopted family members, we're not going to have a whole lot of relatives to figure out whether patterns here or not. We're going to focus primarily on what kinds of symptoms have you had. And it may be that I say, you know what, it looks like you're at an average or a low risk. We may not need a genetic test. It'll still be up to you to decide, do I want to move forward with that? The only good thing that comes from out is a really easy family history. So it's just that we get through really fast. But we've got kind of those two tools. What's your health? Is that telling us something? And if we have it, what's the family history telling? We can use both.
And you may have covered this, so I'm just trying to think. I mean, I know that my siblings and children have similar genetics, but we all have our own unique. So if I have testing done, who can that all help or assist and provide information for?
Yes, if we find a positive result, that's actionable information. A negative basically means we didn't figure it out. You may have a brother or sister who actually would benefit from testing. A negative result in you only tells us your genetics. But it may be that, hey, mom had this, she passed it on to some of her kids. I was not one of those kids. And so we could test a sibling and they may be able to find it. But if you find a positive, now we've got something to work with. There's a specific risk that has been found. Now we know if family members test negative for that, here's the risk. They don't have it. We start with the closer relatives when possible. So if you've got kids, we'll recommend that they consider testing long before we're even talking about grandkids. If you've got a child who tests positive, yes, they could pass it on to the generation after that. But if you have a child that tests negative, here's the risk. The child does not have it. Well, they can't pass on what they don't have. So you don't have to go to the next generation at that point. Same thing with siblings. You have a sibling that tests negative. Well, none of her children need a test. She doesn't have it. She can't pass it on. Now, the more positives you have, the further out in the family you go. And it could be that we're talking about cousins and things like that. But at that point, you may want to find kind of somebody in the family to help you with that. There may be somebody that's really good at keeping track of everybody. Hey, I don't talk to these relatives as often. Well, do you know somebody who does? And you work with them. So overall, if In terms of risk, you start with the closest and see if you can rule it out for the others. But if you keep finding positives, you keep going. If I remember correctly, I think you had asked something a little bit more, how likely most of the things we're looking for. If it's genetic, there's about a 50% chance that a first-degree relative could have it. And so about a 50% chance, maybe a brother or sister, but the further out that goes, it's half of whatever that was. Nephews and nieces, 25%, their kids, 12.5%, but 50% close relatives in most cases.
Well, some people online can.
Stephen, can you explain the difference between consumer tests and what you do testing?
Yes. So the way I like to split these categories is if the genetic test goes on sale, it's not one of our tests. So there are going to be lots of tests out there. You can find them online, you can find them in commercials. If they're going on sale, if that's the sort of thing your sibling got you for a Christmas present, it's not a medical genetic test. Those sorts of tests, there are some things that they're really good at and some things they're not so great at. Some of the things they're really good at, things like ancestry. So how German are you? Or sometimes you find out surprises too, like, was I really related to that sister? I don't know. So be careful with all that. But also, it may determine little things that maybe wouldn't impact you all that much. Like, I think some of them is, do you enjoy the flavor of cilantro and things like that? I'm not too worried if you want to do that for fun. But for medical issues, if you look at the fine print, almost all of those consumer tests, the ones that you can buy yourself, you don't need a doctor for, they're going to say in the fine print that this is not a medical test. If you find something, you need to validate it with a medical test. So I do that for some of my patients. They find something, we're going to see is it positive or not. Some of the statistics on some of these labs are not too flattering, where there are significant issues with false positives and false negatives. So I would say that if you're trying to figure out a medical concern, the consumer test may not be all that helpful. The medical tests also come with more privacy built in. It is a medical record. It's covered by HIPAA. It's covered by that Genetic Information Non-Discrimination Act I mentioned. If you've been paying attention and you're seeing things like, oh, they found a murderer in California because of genetic testing, it's not this testing. So we're talking about medical records. If you're looking into privacy concerns, you have to read their own fine print. So I think one of the things that's come up recently is a laboratory called 23andMe. So they went into bankruptcy and now they're trying to sell their assets as part of that. Well, their assets are genetic data. So they're saying they're not going to do anything nefarious with it. I guess it comes down to a trust issue. So there's nothing in terms of our legislation that really provides protections there. I do think you're going to start seeing that there is a desire for patients who want this type of testing and want the type of privacy protections that we see for our medical records. And that may become a reality, but we just haven't seen that yet. So it comes down to, what are you agreeing to in the company's fine print?
All right, any other questions? All right, I'm just going to check online. There weren't questions when I just checked, but yeah, nice. Nope, nothing new in this chat. All right, all right. Well, there we go. Well, thank you, Stephen. My gosh, I think you took a topic that a lot of us probably didn't know a lot about, and you did a great job making it understandable. So thank you, except for the thing over here and the, that one I kind of got lost on, but that's okay. So thank you. And Stephen will be back in October, actually doing a similar program on breast cancer, correct?
That's right.
Yeah.
And so I'm not sure what all the question answers section are here, but if you feel like there's something here I want to know more about and you think, hey, you're coming back in October, maybe you can let somebody from our group know and I can try to build it into the next one. But we are planning to focus primarily on hereditary breast cancer risk.
All right. So please fill out your evaluations and give us ideas on other topics and presenters, and you can put those in the basket on your way out. Want to remind you, our next program is in 2 weeks, Wednesday, September 27th, here at 60 Forward. It's Understanding Sepsis, a Vital Guide. Then down here, Wednesday, September 10th, they're doing fall risk screenings. And then Wednesday, September 24th, we'll be back down here again, Aging in Place, tools to keep you in your home. So thank you for joining us, everyone, and have a great day. And once again, thank you, Stephen. Thank you.